A routine hospital operation, an experienced medical team, a healthy young mother expected to return home the same day. But within minutes of anesthesia being given, something went terribly wrong, and what followed would change how hospitals around the world think about patient safety. This is the story of Elaine Bromiley. Medicine saves lives every day, but when something goes wrong, the impact can be profound. On this channel, we explore true medical stories, not to sensationalize, but to understand, to reflect, and to raise awareness. This is True Medical Stories because every story matters. Elaine Bromley was a 37-year-old mother living with her family in Buckinghamshire, England. She and her husband Martin were raising two young children in what friends described as a happy, ordinary life. Martin worked as an airline pilot, and safety routine were parts of everyday conversations in their home. Elaine was known as a devoted mother, energetic, caring, and deeply involved in her children's lives. Nothing about that March in 2005 suggested anything unusual was about to happen. She was preparing for what doctors described as a routine sinus operation, a procedure expected to improve her breathing and allow her to return home the same day. For Elaine and her family, it was just another hospital visit. But within minutes of anesthesia being administered, the routine procedure would turn into a medical emergency no one in the operating theater expected, and the consequences would change patient safety training around the world. It was reported that on the morning of the operation, Elaine arrived 7:30 a.m. at the facility on the 29th of March 2005 for surgery on her nose. It is a modern, independent healthcare facility that is situated adjacent to a particular NHS hospital. Prior to admission of the procedure, Elaine had a pre-operative assessment on the 21st of March 2005. At that time, the pre-operative assessment questionnaire highlighted only one matter of note, that she had a congenitally fused vertebrae in her neck. The only other issue noted was that she was using a nasal spray twice a day to help the nasal symptoms. According to report, it was highlighted that the consultant ENT surgeon is an experienced surgeon who has worked for many years both in the NHS and the independent sector. Also, the consultant anesthetist was said to be an established consultant working in both the NHS and independent sector. His NHS colleagues comment that he is a very diligent and caring doctor who practices careful anesthesia along with his colleague. On arrival in the anesthetic room at about 8:30, routine monitoring was set up. This was blood pressure cuff to measure blood pressure regularly during the operation, ECG, which monitors the heart electrical activity, and a pulse oximeter, which monitors the oxygen level in the blood. Shortly after, doctors realized they were unable to secure her airway. They could not insert the breathing tube, and they could not ventilate her properly. In medicine, this is one of the most dangerous emergencies an anesthetic team can face. It was reported that Elaine's oxygen levels began to fall to a very low level, as low as 40%. Attempts to ventilate the lungs with 100% oxygen using a face mask and oral airway proved extremely difficult. In combination to the extremely low oxygen saturation, the heart rate had declined to 69 beats per minute, with a downward trend continuing to the low 40s. This is indicative of lack of oxygen to the heart. By about this time, other staff came to the anesthetic room to provide any necessary assistance. The team attempted multiple intubations. Each attempt failed. Minutes passed. Two nurses reportedly suggested performing an emergency surgical airway, a last resort procedure. But the team continued trying to insert the breathing tube. Elaine's oxygen levels kept dropping. In view of the problems encountered, it was decided to abandon the procedure and allow Mrs. Bromiley to wake up. It was reported that one nurse went out to phone the critical care unit as she was shocked at Elaine's vital signs and color. On return, she announced that a bed was available in intensive care. She was dismissed, so she went back to the phone and cancelled the bed. Another asked her colleague to fetch the tracheostomy kit. On her return, she announced to the consultant that the tracheostomy set is available, but she was ignored. Eventually, an oral airway was inserted and oxygen saturation gradually improved, reaching near normal 95%. Throughout this time, the blood pressure went as high as 192 over 126, and the heart rate was also very high, up to 152 beats per minute. Elaine was transferred to the recovery room once the anesthetist was happy that she was breathing satisfactorily with the oral airway in place, and expecting Elaine to recover consciousness slowly. However, even nearly 1 hour after admission in the recovery, there were no sign of recovery of consciousness, and whilst Mrs. Bromiley was breathing, the pattern was erratic. The blood pressure was equally erratic with swings from very high to low. The oxygen saturation equally showed swings. Most concerning to the recovery staff were periodic episodes of movement that looks like fits. Concerns increased, and eventually it was decided that Mrs. Bromiley needed to be transferred to the intensive care unit. Mrs. Bromiley was transferred to an NHS hospital. At this time, she was in unstable conditions, though was still breathing on her own. On admission to the intensive care unit at the hospital, it was clear that Mrs. Bromiley had suffered marked brain damage and urgently required ventilation. Again, there were problems with placing a tracheal tube. Eventually, they were able to insert one through her nose and into her trachea. On April 5, 2005, following discussion with the family and assessment by senior clinicians, a decision was made to withdraw life support treatment, and Elaine died on the 11th of April, 2005. Martin Bromley needed to understand what happened. As an airline pilot, he was familiar with how aviation investigates accidents, focusing on systems, teamwork, and decision making. But he found the hospital investigation focused mainly on individuals rather than the team response. Martin believed something important was missing. Independent experts later reviewed the case using human factors analysis. They identified several problems: fixation on one approach, loss of situational awareness, communication breakdown, and delayed decision making. These issues were not about intelligence or training, they were about how humans behave under pressure. Instead of turning away from healthcare, Martin Bromley worked with it. He became a patient safety advocate. Elaine's case is now used around the world in hospital training, operating theater simulations, and medical education. What can we learn from this? Elaine's story reminds us that even ordinary moments in medicine can carry extraordinary responsibility. And from this tragedy, we can create a lasting change. In an emergency, communication matters, teamwork matters, and listening can save lives. If you found this story important, consider subscribing for more true medical stories that deserve to be heard. Share this video to help keep the conversations alive, because awareness can save lives. Until next time, stay informed, stay compassionate, and take care.